Next, we're going to learn about a junctional rhythm. So what makes something junctional rhythm is what we've already learned. We will have an inverted P wave in lead 2 with a short PR interval, or no P wave in front of something, or even potentially a P wave after the QRS. In a junctional rhythm, one of the things we need to remember is that our AV node plus the bundle of His makes the AV junction. One of the things our AV node and the AV junction can do for us is we said normally when the SA node fires, it sends the impulse through to the atria, and then the AV node holds that impulse for about 0.08 seconds, giving the atria actually time to contract and finish filling the ventricles. The other thing our AV node does is it can block impulses. So in atrial flutter and atrial fib, which we learned about in earlier classes, if the AV node is being bombarded by lots of different impulses and it's firing too fast for the ventricles to handle, the AV node can actually block impulses to protect the ventricles. The other function that our junction can do for us is if the SA node fails to fire, if for some reason there's a disease process and the SA node literally just quits firing, that junction can kick in as a backup system, not because it's irritated, but because it's trying to help. So in a true junctional rhythm, it's when the higher pacemaker sites have failed and the AV junction is left with the pacemaking responsibility. The atria are depolarized via retrograde conduction, so backwards conduction. The ventricles will still conduct normally. The normal inherent rate range for the junction is 40 to 60 beats per minute, because we learned that the fastest thing will pace the heart. That is normally the SA node. It normally fires at 60 to 100. So this is a backup system. This is the SA node doesn't fire as a backup rate. It's going to kick in between 40 and 60 beats per minute. The AV junction is a regular pacemaker, so R to R to R will be regular. And the P waves, as with any of our junctional rhythms, we will have an inverted P wave with a short PR interval in lead 2, or we will have no P wave, but a normal size QRS, or we could even potentially have a P wave after the QRS. Now this example right here, this is really only showing about a 3-second strip, a little over 3-second strip, but R to R here is normal, it's regular. In a 3-second strip, because I only have 2 hash marks here, my rate would be 40. I do not have a P wave in front of the QRS, but I have a normal size QRS, and then I have a P wave after it, and then it goes into the T wave. So this is going to make this a junctional rhythm. So we would chart this JR at 40. You always want to include the rate. Now here's another example. This is showing you a junctional rhythm in lead 2, and it's also showing you a junctional rhythm in MCL at the same time. So in lead 2, I can see that QRS to QRS looks normal. If this is a 6-second strip, we'll assume it is since it's not marked. I have a rate of 40. I have no P wave in front of the QRS. I have a normal size QRS and a normal T wave. So this is going to make this junctional. And sometimes when you're not sure what you're looking at, we can figure out what it isn't. I know this is not a sinus bradycardia. I don't have a sinus P wave in front of it. I know this can't be atrial fib. It's atrial fib, I would have an irregular R to R with no clear distinct P waves. I don't have a clear distinct P wave, but I've got a regular R to R here. And we haven't learned our ventricular section, which we'll be learning next week, but in the ventricular section, we're going to learn that our QRS would have a wide and bizarre looking QRS generally. So this is going to make this a junctional rhythm, so I would chart it JR at 40. Now this example here, QRS to QRS to QRS to QRS to QRS is regular. My rate is 1, 2, 3, 4, 5, so a rate of 50. I see that I have an inverted P wave, and then it goes immediately into the QRS. There isn't that hold like we usually have when the AV node normally holds it. When I try to count my boxes here, it looks like I'm 1, 2, it's like a little over 2 boxes, about 2.5 boxes, so 0.10. So that makes this an inverted P wave with a short PR interval, normal QRS size, so this would be JR at 50. Now this example here, I'm going from QRS to QRS to QRS to QRS to QRS. So again, my spacing is regular. My rate looks like I'm a rate of 50. Again, this one here, I do have an inverted P wave with a short PR interval. It's really hard for me to tell these boxes here. When I put things in PowerPoint, sometimes my boxes get a little bit skewed, but it looks like I'm only about 2.5 boxes here, so 0.10. QRS is a normal size, so this again would be JR at 50. Now here's another example where I have QRS to QRS to QRS to QRS looks normal. My rate here is 1, 2, 3, 4, 5. I have no P wave in front of this one. Now here my QRS looks a little off. It does go up. It goes for an R wave, and it looks like my ST segment is depressed, and then I go into my T wave. So I do have some ST depression here. But my QRS size itself, because it distinctly notches or changes directions here, my QRS is only a little over 2 boxes here. It's right about 2 boxes, so 0.08. So here I would actually document this one, JR at 50 with ST depression. Now, one thing we have to remember with ST depression can be a sign of old injury. It can actually be acute injury if it's due to reciprocal changes. So you have ST elevation in some leads. You can have reciprocal ST changes in some of the other leads. But sometimes we get confused when we have bundle branch blocks. When you have wide QRSs, then you get secondary ST changes and T wave things just because of the bundle branch block, not because there's any ST issues going on. It's part of the bundle branch block. But this one here, my QRS is a normal size. So this would be JR at 50 with some ST depression. This one here, I have a regular R to R to R to R to R. My rate is 50. Seems to be an ongoing rate here. I see I have an inverted P wave, and then I go immediately into my QRS. Looks like my PR interval is around 2 boxes here, so about 0.08. QRS size is normal. So this would be JR at 50. Now this one here, this wasn't a full 6-second strip. It's marked up here. I only have 3-second markings. So this would make this one a rate of 40. But again, I see that I have an inverted P wave, and I go right into my QRS. And it looks like my PR interval is 1 to about 2.5 boxes. So this is going to make this JR at 40. QRS is a normal size. And here, now one thing we talked about with QT interval, now this one here, the QT interval looks like it's just a little long. Well, actually, no, our QT interval looks like it's right at 0.40. But remember with our QT interval, from the beginning of the QRS to the end of the T, it's 0.40 or less in normal heart rate ranges. In slow heart rates, sometimes it can lengthen just a little bit. This one here, regular rhythm, my rate here is 40. I have an inverted P wave, and I go immediately into my QRS, giving me an inverted P wave with a short PR interval. QRS size is normal, QT is normal. So this would be JR at 40. Now this is what junctional rhythm looks like in a 12-lead ECG, and you can tell depending on what leads you're looking at, it can kind of skew what the reading of it looks like. On this one here, it doesn't look like I have any P wave. Would have been nice to show you the P wave in it. So in lead 2, it's always an inverted P wave with a short PR interval, but in a couple other leads, you sometimes might still see a positive one with that short PR interval. But in lead 2, it will be inverted. So, but this one here, I have no P wave in front of this, normal size QRS. So again, a junctional rhythm. So as far as what can cause junctional rhythms, sometimes it's caused from the SA node just being unable to fire at its normal rate. Other causes include MI, congestive heart failure, atrial enlargement, drug toxicity, acidosis, and anoxia, just lack of oxygen in general. So the significance, if you're going to have symptoms from this, it's because your rate's slow. So it's not because it's coming from the junction that causes the problem. It's because the rate's 40 to 60, which is the problem. So if you have a symptomatic bradycardia, as with any bradycardia, remember our cardiac output is stroke volume times heart rate. We have the diastolic phase, we have stroke volume, we have time to fill, but because our heart rate's lower, it is decreasing our cardiac output. So we might see things like dizziness, lightheadedness, drop in blood pressure, possibly chest pain, shortness of breath. It can actually cause coronary insufficiency or cerebral ischemia. So you might see, just poor perfusion up to the brain. Sometimes when you see really slow heart rates, your heart will try to kick in extra beats just to try to help. But generally, this is already a backup system for you. So we try to treat the cause if possible. Why is our SA node not kicking in? Otherwise, it's not a specific drug because it's junctional rhythm. It's a specific drug because it's as if it's a symptomatic bradycardia. And as with all of our symptomatic bradycardias, we're going to treat it with atropine, 0.5 milligrams. It's a rapid IV push. Atropine can be repeated every 3 to 5 minutes to a max dose of 3 milligrams. Another option we can do is we can do an external pacemaker. If atropine isn't working, we can consider pacing the heart with an external pacemaker. Another option is a dopamine drip. Dopamine is kind of a nice medication. It does support blood pressure, and the side effect from it is an increase in heart rate, so we get a twofold benefit from it. An epinephrine drip is kind of unusual to see. It can be done, but it is not something we typically do for routine bradycardias. So that's going to end our segment on junctional rhythm.